very excited about. We have Dr. Mohanad Hamami with us. Dr. Hamani is a health strategist with more than 20 years experience in public, government, and healthcare sectors with a focus on community health and wellness. He served as a Trinity Health Senior Vice President for Safety Net Transformation, Community Benefit, Health and Wellbeing, where he led the strategy to improve the health and the underlying social determinants of health in communities served. He also served as Chief Health Officer and Director of the Department of Health, Veterans, and Community Wellness in Wayne County, Michigan for almost 10 years. He is a medical graduate and holds a master's degree in Health Service Administration from the University of Michigan in Ann Arbor. Dr. Hamani, it's a real pleasure and an honor to have you with us. Very much looking forward to your presentation.
Thank you, Jose. Good to be here. So thanks for the opportunity. Good to be here virtually. And what I wanted to share with you is a little bit of the lessons learned when I was at Trinity and community wellness, specifically how we had to deal with it in the midst of the pandemic that we are still going through. So just to go back to some of the basics of understanding, when we talk about health, then we mean the complete wellness aspect with the 8 dimension of wellness, specifically how the interaction between emotional, social, cultural, and economic wellness all interact together. So to many of you, I'm probably preaching to the choir, but usually when you preach to the choir, you get a, you get a bigger amen, I guess, or a stronger amen. We all know that whatever we provide in terms of healthcare accounts only for 20% of what makes a person well. So between 20% of healthcare, including some genetics, the rest is certainly health behaviors, physical environment, as well as the socioeconomic factors. And these are what usually people reference as the social determinants of health. We like to call them the social influencers because once something is determined, then it's hard to change. But as an influencer, then you can certainly influence the influencer and you can certainly act upon it and try to minimize its effect on health. A lot of the examples that are listed under the social influencers or the social determinants are housing, education, income level, the place where people live, not only the environment, but also the built environment, the social support. And recently, as we have witnessed, the discrimination and racism is truly something that impacts how healthy people can be or how negative it can be on their health. And unfortunately, in the past 20 years or so, the U.S. healthcare has been, although the social determinants or the social influencers have been at the forefront, they were more of a buzzword. We continue to fund clinical care up to 95%, and whatever makes people healthy, which are the social influencers, we invest less than 5%. Even when I was at Trinity, we had a $1.2 billion budget that is our community benefit budget. Of this, almost 95% was going to uncompensated care, going to clinical care and safety nets. But to truly invest in the poor and underserved communities was less than 5%. And that model, if we truly want to shift the needle, that model has to change, and we need to invest more in what makes our communities a healthier place for people to live in. So, health disparities is something that have been amplified, and we've been hearing about it more and more. I say that the only or one of the few positive things that came out of this pandemic is that people started understanding what inequities are and what health disparities are. So this is the definition of the National Institute of Health of what health disparities are, and it is how the differences of disease prevalence and the effects of a disease exist among specific population and groups. And we know that disparities can be based on race. This is, for example, the age-adjusted HIV or AIDS diagnoses, and the yellow bar or the orange bar that you see that is high in each one of these clusters are the African American population. And there's certainly disparities between Hispanic, white, and African Americans. We also know that the disparities are based on income. This is, for example, the health of children based on poverty level. And regardless whether you are at the higher income, the poorer income, or the lowest income, there are disparities between the three income levels, depending on where you fit on the economic scale, but there's also disparities within each one of those income levels based on race as well. So it's kind of like a double jeopardy. And again, I'm not telling you something that you probably do not know. Many of the determinants of equity are rooted in the what we provide for people, the opportunity for people to advance, whether it's education, whether it is job, whether it is economy, whether it's access to parks, whether it's availability and access to transportation, in addition to access to quality healthcare, which we are not diminishing that you truly need a good healthcare infrastructure. But in addition to that, you need to avail all these to ensure that people are healthy. So we take that and we apply it to a whole community at the community level. And when we talk about community health and well-being, and this was the mission of community health and well-being at Trinity, my department, is to optimize wellness and equity and eliminate disparities. Three things that are connected to each other, but it's truly a more complicated approach to how do we leverage all these together and ensure that communities are prosperous and are conduits for people to practice health. And the approach is twofold. So it's certainly on the individual level. So our patients, this is when we talk about health systems, the first encounter you have with any member of the community is them walking through the door to your clinic, and they come manifesting with clinical symptoms. But you also need to understand they came from the community and they're going back to the community. So you need to understand what did they bring with them and what are you sending them back with. So this is where you address their needs, not only their clinical needs or the disease itself, but you also look at their individual needs, their social needs. And then we need to improve community conditions because, again, they are coming, as I mentioned, they're coming from the community and they are going back to the community. So we need to ensure that the diabetic, for example, that we are sending back to the community has access to fresh fruits, have access to food sources, have access to physical activity, or even have access to a refrigerator to keep the insulin with constant electricity. So all these are things that integrate the social factors into the clinical care to make sure that outcomes are optimal. So let's focus a little bit more on disparities, and specifically when we talk about the poor and underserved. So we know that these groups include those that are of racial and ethnic minorities, specifically African Americans, Hispanics, immigrants, people that are of low income, people that are experiencing homelessness, and another vulnerable population are those that have serious mental illness or substance use disorder, and specifically those that are living in group homes and in residential settings. So all these are things that we saw in a normal community before the pandemic. But what happened when COVID-19 hit is that we discovered that one, COVID-19, although it can affect everyone and infect everyone, but the impact of it, it's not distributed equally. We saw a lot of African Americans that we know from previous data have more underlying conditions, have more social risk factors, and therefore we saw a higher percentage of infection as well as a higher percentage of death amongst African Americans. We also saw a lot of the essential workers that are at risk. And if we look at the demographics of essential workers, then people of color make almost half of all the essential workers that work in the food service or in the agricultural industries. We also see them at more than 50% in working in basic services, transportation, and all that. And most of them come from, to start with, come from a underrepresented or disadvantaged. 70% of essential workers do not have a college degree. And the distribution between those that work in community-based services are more women versus men that work in service areas. So the essential workers we know are more at risk when it came to COVID-19 and exposure to it. Then add the homelessness, which at any given year, there's about 1.4 million people living in shelters or in the streets in the United States. And this provides a very big challenge when we talk about a pandemic, because one, this is a transient population that we cannot isolate, we cannot track, we cannot tell whether they're infected or not. So these are floating across the system, and it is very hard to keep track of this population, which makes it even more risky to be infected, but also more a transmission infection. So if we go back to what we talk about when we talk about community wellness or community health and well-being, then if we want to take a look at it under the lens of this pandemic and what we needed to do, there had to be a new way of shifting our efforts. We also know that the pandemic has placed an extra burden on an already disadvantaged population. There were a lot of unemployment, either furloughed or people that were dismissed from their work because of closing of restaurants. Again, we're talking about essential workers, closing of schools, closing of a lot of places where that meant unemployment was rising. With unemployment, there was a loss of the affordability of health coverage, or if you had health insurance that come through your work. There were a lot of food insecurity due to the isolation or people unable to provide food. There were some people that moved into shelters or lost their homes. Certainly financial stress, add to it the mental stress that added to dealing with a pandemic and dealing with the impact of it on a family basis, but also on an individual level. And finally, especially for those that are elderly and they were quarantined or forced to isolate, then the social isolation impact was very evident in many of the people that we saw. Also, the pandemic has disrupted what we had as a safety net, the resources that were in place in a community. A lot of the funding shifted, so many of those community-based organizations, the nonprofits, were lacking funding. The safety nets, these are the clinics, such as the free clinics and all that, had to either shift everything towards the COVID-19 cases, or they had to close because, again, they opted out of outpatient operations. We couldn't ask volunteers to participate in events because we were afraid of the safety of those volunteers. Many of our volunteers would go to homes and check on people and all that, and that was a big no-no, especially in the beginning, the first month or so of that. Large community events such as health fairs, food distribution, all those had to be stopped and then re-engineered and reorganized to make sure that we are limiting the transmission of the disease. So we needed to shift our focus and shift our resources to address the impact of the pandemic. And we focused on these 5 major themes. So certainly we wanted to ensure that everybody had access to testing as well as access to clinical care. With that, we also understand that the social needs are now at a higher and more amplified need, where they became more crucial as risk factors. So although we are addressing someone's the impact of a disease on someone, then we needed to understand what does it mean in terms of transportation, in terms of food, in terms of shelter, in terms of childcare, for example. All those are things that we needed to take into consideration. The homeless population and how do we outreach to the homeless and how do we provide support is certainly something that had to be addressed. And we understand that communities are different and we're dealing with different populations. So educating our populations about prevention, about the importance of social distancing, the importance of wearing masks, but also the importance of prevention in a culturally competent way. One of the things we noticed in one of our locations in Hartford, Connecticut, for example, is which was predominantly African American, is one of the messages that was plastered all over the billboards and even on TV. You might remember the ad council that says, whether you have COVID or not, stay home. For some people, that meant that even if you're sick, you have to stay home. And we saw a higher prevalence of people that are very sick and not coming to the hospital or not going to see their doctor, because this is what they understood. If you're sick, you just stay home and you do not go out. So this is where the messages had to be tailored to a level where our population can understand it. And finally, of course, the behavioral health support, not only for those that are affected in the community, but also we noticed a lot of healthcare workers, a lot of our frontline people, the essential workers that are burnt out, and they are not only worrying about the people that they're serving, but they're also worrying about going back home and infecting their family. We heard a lot of stories about people sleeping in their cars after their shift because they didn't want to go back home and put their family to rest. I'm not going to go through this whole slide. As you can see, Trinity is a national health system. We're in 22 states with almost 95 communities. But what we learned from this is that no one community is alike. You cannot go and have a standard implementation of one solution. You had to truly understand the needs in every community, and then you had to ensure that what you are putting in place is something that is needed and it's going to benefit the community. So a lot of the lessons that we learned and some of the examples that I'm going to share are based on the experience that we had. So we learned that social care is as important as clinical care. And this is where we established a social care hub in every place where team members connected with patients, but also it was available for community members, either virtually through our website or through a physical location where they can call and ask for advice. These local services, such as food, housing, financial assistance, childcare, and also access to medical care as well. Another thing that we were looking at is monitoring almost on a daily basis the availability of the community-based resources. We know that a lot of our community organizations that are dealing with, like the food pantries, were in dire straits or they needed more supplies. So this is where we wanted to ensure that we have the capacity to refer someone for those services. And a lot of the support went to ensure that those community organizations are okay and they are functioning well. We also connected our patients to frequently we gave them a resource directory that they can access and find out what services that are available and what they can need. This is during the period of the beginning of the pandemic, as you can see in mid-March, and it goes to mid-May where we had the peak. And when we started the social care hubs, then you can see in the left-hand corner how fast those services have been, or those needs were identified and how they were provided. The same way was also for those that called and inquired for medical need and medical access. So the two graphs that you are seeing show that really people are in need of both services. And this was under what we called people under investigation. So these are people that went and had a test and they either got the result of the test or they were waiting for the results. So there was a 24-hour period until they got the results. If they were positive, then they went into quarantine. If they were not, then we follow on them every week to make sure that nothing has changed. But during that period, they were asked whether they needed assistance with food, or assistance with shelter and all that. And these are some of the data. Also, the Community Resource Directory, that was a link on a website where people could go and type in their zip code and what they're searching for. And we partnered with Aunt Bertha, which is a web-based community resource directory. And as you can see, the majority of the inquiries that happened during that month between April and May were looking for food and housing, and then health came in the third category. We also understood that there were barriers to testing, not only barriers because of the lack of available testing, but with that, there was a misdistribution or an inequity in distribution for the tests. We wanted to ensure that communities have access to testing. So community-based testing, either through drive-through events, but even the drive-through event has a barrier for those that do not have transportation. So we started having walk-in or walk-through testing sites, or we dispatched many of our mobile units. The mobile units usually were just for health education, some basic screening. Now the mobile units became testing sites as well. So this way we alleviated some of the transportation barriers. We would take a mobile unit and put it in front of a homeless shelter and test the homeless and make sure that we are keeping track of that. And we wanted the testing to also address the cultural differences. So a lot of the services were translated to whatever the predominant language was in that community. We, as I mentioned, the homelessness efforts were very focused on, for example, our Atlanta-based health system partnered with many of the organizations. They benefited from a strong support from the state, where they rented a Holiday Inn in the downtown area. They did perform the testing. They partnered with the university in making sure that education is happening. Anyone that needed isolation was taken to the hotel where their basic services were met, and also their medical needs were addressed. And in some other places, we provided toiletry stations and under bridges, or where we know the homeless that cannot seek shelter are found. We distributed a lot of the personal protection equipment, such as masks and sanitizers and all that. We also looked at the population that was in jails and hospitals, and when they were discharged, making sure that they have a place to go, or they are connected to a shelter that they can go to where they are protected. There is no less importance, no greater importance than making sure that people are aware, and the communication campaign. So that had to be where you come in as a trusted partner, and that meant engaging a lot of community leaders to provide the education and understand the community and what message they need. A lot of phone banking. We distributed door hangers in multiple languages. We did a lot of social media and radio and TV ads, ensuring the importance of masks wearing, face covering, the social distancing, the sanitizing, and the importance of, if you're sick, then just make sure that you stay home and you stay isolated. One thing that we are still challenged with is the availability of data. And as many of you probably know, a lot of the data that is collected, very few states, when they collect the COVID-19 data, whether it's positivity or confirmed cases, or even people that go on ventilator or die, does not specify race, ethnicity, or insurance status and all that. So we are emphasizing the need of having that as a mandate, and ensuring that we collect that data, because that data is going to be very helpful in identifying where the hotspots and the most people that are at risk in our communities. And with that, we can also have a profile to understand whether there is unintentional bias in treatment, testing, and intervention from the health system that is in the community. It also would help us to determine where we need to focus our testing and our prevention efforts and all that, and what communication campaign or what messaging needs to be implemented. I am currently helping Wayne County, which is my county in Michigan, with their COVID response, and we're putting a strategy specifically that is targeting community-based testing. And the first thing that we are doing is we're looking at what communities amongst the 43 in the county have the highest prevalence and the highest positivity rate, especially the trend, and trying to understand a little bit why this is happening. So one example is the city of Dearborn, which is where a high concentration of Arab Americans are. And because of the cultural differences, because of the multi-generational interaction in one household that this population has, we believe this is why there are higher cases that we're seeing in that community rather than in others. And our approach to this is going to be quite different than if we are targeting, let's say, the Grosse Pointes, which are the more affluent population in Wayne County. Finally, we certainly need to understand the behavioral impact and the stress on the community as well as individuals. So a lot of support needs to be put in towards hotlines or warm lines that help individuals, and not only, as we said, those that are impacted, but also those that are the healthcare workers and the frontline workers. We need to ensure that group homes and residential settings where substance use or rehabilitation is happening put in preventive measures, and we need to maintain the essential services in the community. Although we are still in some places in shutdown mode, we need to ensure that these are still happening and we are providing crisis intervention services in those communities. So to recap, we know that COVID-19 has amplified things that we already knew that were affecting communities in terms of amplifying the social risk factors and the social influencers of health. And it did affect those that are poor and vulnerable and certain ethnic groups more than others. And it exposed disparities and inequities in both the morbidity and mortality, again, within these populations. And in order to ensure that we are addressing the impact and mitigating the impact at the community level, then a change in the shift and the refocus on how we address community wellness has to be put in place in order to minimize the effect and the impact of COVID-19 in our community. I'm going to stop here, and I'm sure that there might be some questions that need to be answered.
Dr. Hamami, what a great presentation on the social impacts of this pandemic. So many great insights from your review. I'm gonna keep monitoring for additional questions here as you're presenting. But one of the things that has emerged has to do with perhaps some of the options that we may have in addressing these inequalities going forward. As you said, if there is a benefit from the pandemic, is that it has exposed to a wider audience what those inequalities are. What would you say are the main areas of potential improvement when it comes to addressing these inequalities going forward?
Well, certainly it depends on how we are looking, from which side we're looking at it. So from health systems, understanding that it is no longer, the health system role is not only to provide clinical care. So the health systems are still going to be the first where those COVID patients are going to come in. So putting a tool that is going to screen for the social risk factors and connecting them with partnerships or whatever the system can provide, connecting them to some of the services that are in the community, supporting some of the services in the community, is going to make that intervention complete. It's again, as we talked about, it is no longer efficient to address the disease itself. We need to look at it from a complete and holistic approach and make sure that we are addressing all that. Many of the nonprofit health systems have for IRS requirements that need to invest in communities. And I think this is where some of this investment is put in a smart way, in a more impactful way, and looking at beyond what happens within the hospital walls or the clinic walls.
Very well. William Fuller from Oregon asks about, he first states that the pandemic has significantly increased the demands against community health budgets. And how has Trinity and maybe organizations, healthcare organizations in general, shifted or acquired the funding to address the shortfall? And how much more may be needed to address that?
That is a great question. And unfortunately, the answer isn't as simple. Many of the health systems we know have been challenged financially due to many reasons. Cut down on elective surgery. There was a period all the outpatients, they were only seeing COVID patients and all that. What we did in Trinity was at a little bit of an advantage, although we experienced that financial challenge similar to any other health system. Trinity had a budget for community wellness to start with. So it wasn't only the community benefit, which some of you are familiar with that term, such as uncompensated care. There were annual budgets that we put into programs that we called programs for community empowerment or community improvement. Immediately what happened when COVID hit is that we went into two things. One, we downsized, whether you like that or not, but we had to put our priorities straight. But then we shifted everything to specifically address COVID. So we had a project that was in its last year that was called Transforming Community Initiatives. And this was a lot of advocacy, a lot of building community coalition and all that. We instructed those 8 communities that were provided and that were participating in that project to put everything on hold, and whatever is remaining from that grant, what would they do based on the needs in their communities? And everyone came up within 1 week of a plan to address a COVID need. Many of it, I can tell you, almost 70% went to food emergency. They found out that the food pantries, the food system had to be, and everything shifted there. Some of them went into the shelter and housing. So this is where you have to be flexible in how are you using your available funds, but also you have to look into the future and say, are we putting our community benefit dollars into things that are going to leave a better impact? Or are we, I give an example, health fairs. So in normal days, every hospital, I'm sure, participate in at least not 1 or 2 or even 5 health fairs. And although I will not minimize the importance of a health fair, but instead of $10,000 for one health fair times 5, that is $50,000. What can you use that $50,000 in something that would provide you more sustainable and impact? So this is where looking at community resources and looking at your role as a health system, how can you be smart in your investment?
And Dr. Hamami, what in your assessment, what would be the best levers, if you will, to pull if we have to allocate those resources? What does the research show? What does your experience account for when it comes to perhaps the most important factors if we can direct funds to?
Again, it depends on what is needed in the community, and this is where the community health needs assessment is your most powerful tool. Whatever you discover, if that community health needs assessment is done the right way, i.e. looking at everything beyond your hospital data, looking at the community demographics, the community profile, then this is where your recipe for you need to prioritize. Another thing that I need to also mention is that you do not exist in a vacuum. This is not a one entity's job. The health system isn't into apartment renting. The health system isn't into community gardens, although some do. So there are people and entities that are out there that are doing a great job. How can you collaborate, partner, and support, and make sure that overall the winner is the community? So partnership is a very important thing to establish, and even bringing other competitors, other health systems, because again, so many cliches that we use in this space, power in numbers and efficiency and all that, these have to be practiced in order to make sure that we are addressing this.
Very good, and you emphasized that well, that there's some global aspects to this, but a lot of the priorities are set locally depending on the needs of that community. Now, in the what about the healthcare providers, and what is their role in this system? Because there has been quite a bit of discussion about healthcare providers. The Institute for Health Excellence, as an example, shares some incredible data about the burnout levels of doctors and nurses before the pandemic, and we all know that it has escalated probably exponentially since then. Curious about how what role do they play in the system as providers, but also as part of the community?
The healthcare providers are, again, the front line. They are the connection between community members and everything from a health system perspective. You probably and we trust our doctor more than we trust anybody else. So this is where the healthcare provider has to be proactive in addressing some of the social needs. Unfortunately, and up till recently, many of the primary care physicians understood the importance of the social determinants or the social influencers of health and its interaction with what make people healthy. But many of them opted, and there was a study, I think, by the Institute of Medicine that showed that 80% of primary care physicians do understand the need to screen for social risk factors, but they don't do it because they don't know what to do with it. So that stomach ache that doesn't show any physical etiology, but it is because of hunger, a physician cannot write a prescription for a meal, and even if he or she does, no one is going to reimburse him for it. So this is where a system put in place that incentivize financially, but also is, and this is where value-based come in place, because by addressing all those, you're improving the outcome. And if we're shifting to an APM model where the value and the outcome is more now of the volume, then this is where physicians need to understand that by addressing these needs and catering to those interventions, then this is how they are helping their patients and making sure that the outcome is better.
Very well, very well. And when it comes to the role that health systems play in addressing community wellness during pandemics, and also contrasting that a little bit with the role of the government, what is the balance that we should strike on that?
The government certainly has a big role in ensuring that some of the policies are changing. So specifically, let's look at behavioral health. Behavioral health is very challenging even in normal times before the pandemic, due to many of the legislation that whether it's billing and reimbursement, whether it's allowing certain things to happen or not. There is also a workforce that is lacking. So all these are things that the government can step in and improve. Health systems, on the other hand, are also members, they're anchor institutes within the community. And if you're familiar with the anchor strategy, then it is hiring locally, sourcing locally, and investing locally. Big systems that are in a community can provide a lot of economic opportunities on those three levels within a community that can change the whole policy, environmental, and system change is something that health systems can contribute to. So by policy, this is where the government comes in. The health system has the role of advocating for. And we have seen, even during the pandemic, a lot of these policies have changed. And a lot of it was a result of those that are on the front line and health systems that were advocating for a better way, or minimizing or removing some of the restrictions on things that were in place. For example, telemedicine. We saw a lot of those restrictions lifted on who can do it and how you can get paid for it and all that. And this is what we need, a more flexible government when it comes to policies, because this is what is working.
Very good, very good. I'm scanning for additional questions. Apologize. I'm scanning for additional questions here, and I have one from Steve Hardacre, who is actually attending this from Hong Kong, and so it's evening in Hong Kong right now. Steve, great that you stayed up this late to be a part of the conference. And Steve asks, from a community healthcare perspective, where are we better and worse prepared across the United States for what's likely coming this winter with the spread of COVID-19? And what, if anything, needs to be done immediately to address that?
That is a very good question. Depending who you ask, there are two schools of thought of what we might encounter this winter. So certainly having a flu season is going to add probably more burden to those that are experiencing COVID-19. The symptoms are the same, so you will have a lot of people that are rushing for clinical care, and this is where understanding who's who is going to happen. Another theory, which is probably the more optimistic theory, is that because of all the precautions that we are taking in place, because of the social distancing, the covering and all that, we might have a much more softer flu season because of the contamination. Regardless what it is, what we are preparing is certainly the ability to test. So increased testing capacity to immediately define whether this is a COVID case or a flu case. Increase the capacity of hospitals and ICUs and ventilators in case we hit another surge like what we had in April. These are the most two that are very important in preparing. And of course, continue to deliver the message of the importance of prevention and protection and all the practices that we know are effective.
Dr. Hamami, we'll finalize with a question on, as you know, healthcare. We have healthcare providers, healthcare transformation leaders, operational excellence in our audience, and of course, you know, citizens of communities. What can we do in these different capacities, if you will, to support community wellness going forward?
I always say it takes a village. So everybody has a role, whether you're an educator, whether you're a business, whether you're a healthcare professional, or whether you are a community member. Again, coming together and putting all the resources towards the benefit of the community is essential. Some of us can do it better than others. Some of us have expertise in one field versus the other, and this is where putting the brain power together is going to be very helpful. Starting from an understanding that not everyone is going to be equal in how they can access resources. Not all communities have equal opportunities to protect themselves or respond to that. And starting with those that are most vulnerable is something that has to be the first step. We always talk about equality and equity, and we need to start thinking more in an equity term. Equality is giving everybody the same. Equity is giving those that need more resources, and that's what we need to do.
Very well, very well. I think for this audience that focus so often within organizations on end-to-end process optimizations, as an example, as opposed to the more common segmented approach to process optimization, what you have done for us today is to expand the end-to-end process of social healthcare, and I think that you have broadened the horizons and shown us that the end-to-end process, if you will, for healthcare is much wider than most people have probably perceived it to be. And if there is any, as you mentioned before, if there is any benefit from this pandemic, is that probably we all have become more aware of that. thank you so much for sharing your expertise, your insights. It's a true honor to have you with us, and our global audience certainly appreciates everything that you shared today.
My pleasure. Thank you, Jose.
Thank you. Ladies and gentlemen, this concludes this segment, and we are going to get ready for the top of the hour to shift into another global impact area, and that has to do with global healthcare supply chains. Supply chains for healthcare have been significantly disrupted and dislocated, and there is really a lot of uncertainty about how that's going to look going forward. With lots of issues related to the supply chains themselves and geopolitical issues already taking place. So with that, we are going to have an expert on that from the Mayo Clinic. Erich Heneke is going to be here with us, and he's going to wrap up our conference with a view of the impact of COVID-19 on the global healthcare supply chain, and specifically how it affected the Mayo Clinic. And so really look forward to meeting you back up at the top of the hour and enjoying Erich's presentation. So thank you. I'll see you soon.